Thank you so much for that very helpful overview and framework. I do want to start by making one point, and then I'll turn to the rest of the panelists to weigh in. I was struck by the fact that you started your presentation about GLP-1 agonists with positing that it's an environmental change that has actually caused this difference. But we're having a conversation about fixing bodies, not fixing environments, which just felt important to say.
Well, doesn't that speak to whether the focus is individual or population-wide?
Yes.
Right.
No. Absolutely. Right. Absolutely. So, I mean, you gave us quite a daunting picture of some of the risks associated, also some of the benefits, but some of the risks associated with the way that this technology is currently being deployed, some of the challenges with how it's currently being deployed. I wonder if we could start by asking the panelists, to respond to any points that Bill made that you really want to respond to, but also to talk a little bit about where we would like to get with this technology. Like, what are we steering at? Using the heat map, summoning all of the conversations from this morning, where are we trying to point this technology?
I'll go first.
Sure.
So in terms of Bill's presentation, I think the one thing we have to address is the stigma, and Bill did a good job about that. As someone who lives with obesity, our challenge is that, society has blamed people with obesity for all the ills of society, right? Our healthcare costs are higher because of that. Lifespan is shorter because of obesity, et cetera. And now new interventions come forward that actually can help us. And then society is saying we're not worthy of those, or these interventions are too expensive. No matter what, we can't win, right? So there's a stigma about needing, having obesity, but there's also a stigma around needing help for your obesity, and Bill did a great job around that. I think one of the things and that I think, moving forward is, this is a space where we clearly have to have conversations around equitable access to therapy, right? And there are groups like mine that have been advocating for this for a long time. I think Bill's opening comment saying that this is actually not just a GLP-1 problem in the obesity space. We've always had a problem with equitable access because most insurance, most government payers, et cetera, exclude these services, right? And we've only been able to kind of force open small amounts of the care around this. And so really to solve this issue, it's going to take our friends in the federal government to step forward and say, you know what? It's time to require payers and themselves, or the payer most of the time, to cover this care, and then they can negotiate better prices, because one of the realities is these drugs are too expensive. It's going to take the manufacturers of these medicines to be open to lowering these prices. You can't have life-saving and life-changing drugs and make them only for rich people, right? That's a reality. Acknowledging that we have the pharmacy benefit manager problem, and all the prices that are thrown around in the media are not the actual prices of these medicines. The only person who pays between $1,000 and $1,400 a month is me, because my health insurance doesn't cover these and I have the means to do so. But an insurance company doesn't pay nearly that amount of money. And the other thing I think around pricing that we have to deal with is there needs to be much more transparency, right? This is not just about the drug companies. There's pharmacy benefit managers and others, and honestly, no one knows what those real prices are, and we need to be more transparent about that. And if we can make those changes take place, and then I'll let Dr. Knight and others comment around this, but I mean, there's challenges in the healthcare system itself to make sure, can we have the right conversations, as Bill raised, around diverse communities, or even just having a basic skill to have a conversation about obesity that most healthcare providers lack.
Yeah, I think, and thank you for those opening remarks. One of the things that really I've reflected on is the slide where you showed the increasing rates of obesity over the years. And I think if you showed a similar slide for any of the other chronic diseases, it would not look like that. So as we know, diabetes, cardiovascular disease, even cancer really leveled off 80s into 90s as we had more biomedical advances. And so though we still see disparities in specific communities, if we look at the entire United States, you would not see a line that just continues to increase every year for that. And the one that is, but probably if you looked at the chronic disease that is very prevalent and continues to increase every year, it's obesity. And so where are we trying to get even just to control the expansion of a chronic disease that is affecting millions of people around the world. That's where we need to get. And that's something that, as a healthcare community, we're all individually and collectively committed to. And so that has to bring us to this conversation. I think we're at a very specific point in our history where we now have treatments that are significantly effective. And I'm not trying to discount previous treatments that we've had in the past, but when we talk about medications that would have 5%, 10%, and as we said, doing things that are just based on diet and lifestyle alone can give you that 5%. When we start talking about 15, 20%, that's a very different space. And so even though these are different examples, if we look back to the HIV journey or the cancer journey, they were all really transition points, like when AZT or specific chemotherapeutics, where we saw a significant change in the trajectory of a health condition. So we are now at a point where we have seen a significant change in the trajectory of a condition that is extremely widespread, and we don't have access to a significant portion of the population, and specifically the portions of the population that have the most prevalence. And that's not something we have seen before. And so even when we think back to, again, situations on Hep C, that was probably one of the most recent journeys that had a significant trajectory, we knew the cost, and I think that's a separate issue. We have to talk about cost, but we were able to negotiate and get to a place where all individuals had an opportunity to be cured from Hep C because of a biomedical advance. And we're not seeing that in the same ways. And in one of the comments that Bill outlined was that we likely will see worsening of disparities. I'm waiting on the study, but I will tell you as a clinician, I've already seen it. So I already can tell you that the prevalence rates of obesity in the patients that see me and the prevalence or the ability to reduce excess weight is completely race and socioeconomic based. And we're seeing that every day. And so it's unfortunate that you have someone that will come to me that is dealing with a significant number of comorbid conditions. Their life expectancy is 20 years less than the patient I saw previously, and I have to tell them there are effective treatments that are there, but you can't get it. And that is not something that as a clinician in 2024, I've had to do for any other disease process. And I think that is what brings us to this conversation, and I'm looking forward to also exploring solutions.
So I get the rest of the time to talk about it. I have a lot to say, so let me just pick up a few points. My biggest fear is that the availability of these drugs will shift interest and resources away from prevention of the underlying causes. The obesity in Black women in particular, because of the high rates and greater severity, is an excellent case for this SESTI exercise, because it really gets to the point of how are we going to work around the race-related structures, policies, attitudes. You know, I could give you a list. I have a list here, but I won't read it, of all the different ways, including marketing of unhealthy foods and beverages and other harmful products to Black communities. You know, all the different, everything that's related to racial disparities generally is also related to obesity in some way on that map that Bill showed you. So we've got a double, possibly triple jeopardy if it's synergistic, but the issues affect Black people because they're Black. And that's not yet a modifiable risk factor in this society. So when I listened this morning, which I thought was very interesting, the underlying belief in fairness and deservedness is not established. You know, Victor can say, we all agree with these principles, but we don't all agree with these principles. And what are we going to do about that? Because it's the factors that cause the disparities that are modifiable, but will people allow that to happen and believe that it's not intrinsic? And I just want to make one other point that picks up on something that Bill said that's very important. On the FDA website, you still see mention of race in the category of intrinsic eligibility characteristics for trials. And then later you see text that says the factors that are related to these differences in exposure and drug response and outcomes may be related to environmental, social, economic, and so forth. But that narrative and that perception that when you tick off the box and measure race, you're ticking off something that is intrinsic to that individual. And until I think that's something that we can work on, because there's a list of conditions that where the response is different, where the drug treatments are different, beginning to change if you look at what's happened with diagnosis of renal disease, diagnosis of brain health, the things that have become controversial, lung disease, where you no longer, I hope in lung disease, push the button that says black before you get the final answer, because that alters the algorithm that's being used. That's something I think we can work on, and maybe by removing that perception that it's intrinsic, we could begin to then attack the issues of, deservedness and some of the other things.
Okay, so I can already see that it was a fool's errand to try to pack this into an hour. Taking off from what a number of you have said and trying to sort of use the heat map as a tool as it was intended, in terms of like teasing out the sectors where that in which this technology is evolving, right? And the elements of those sectors where we might be able to deploy governance levers to shift things a bit, right? One of the very first challenges, I think, is you started with a comment about transparency, but then you mentioned the pharmacy managers. Right, the complexity of the ecosystem in just identifying who are all the actors who have levers, governance levers to deploy, and on whom we can exert some kind of pressure or incentive to shift things. Even that, I think, at least from my outsider perspective, and I don't work in this space at all, seems to be a first challenge that we have to address. The other thing, another point I wanted to make about, the background structural racism and how do we even manage that, is a comment that Alondra made this morning actually about childcare in the CHIPS and Science Act. And are there ways that we can address the broader context through this technology? And then the last thing I want to say is just to point everyone to another National Academies report on race, ethnicity, and population identifiers in genetics and genomics research, which addresses some of the challenges that you were talking about of suggesting that race is intrinsic and actually starting to broaden our lens and think about what are the environmental factors, which it strikes me as is being critically important in this conversation as well, like that whole both sets of issues there. So what do you think are from your various perspectives and the sectors that you sit in, what do you think are the most promising opportunities for realignment? Like, where do you see that we might actually be able to identify a risk and a mitigating governance lever for it?
I think this is a really wicked problem.
I concur.
Right. Because how do you find or postulate a technologic solution to bias and stigma, which is at the heart of a lot of this? And I'm not quite sure how to do that. I think the one, and the areas that I thought about, the one potential lever is that would address some of these issues around drug approval and communication of the differences in the pharmacokinetics of obesity in patients with obesity comes back to FDA. I mean, I think that's one potential fix. But I'm hard pressed to think of others that address stigma and bias directly in a structural way, because it is structured, I should say. And how do you undo the structures that maintain that kind of bias and stigma?
Well, FDA also just sort of forecast that it's going to implement different standards for pulse oximeters, right? And the concerns about on whom they were tested, and therefore what implications they. So I can see a model actually that mirrors that. Sorry, others.
So I was thinking, as I was listening this morning to all those sessions, and I've been an advocate in this space for 19 years, and I think that we wouldn't be having this conversation today about this topic if a dozen years ago, when we tried to fix the system, we could have actually done it at that time, right? I mean, I think about, our own governments, who, under Center for Medicare and Medicaid Services says that, Part D and all these other things, basically under Medicaid too, that agents for weight loss, weight gain, or anorexia are excluded, right? And we titled this session "Agents for Weight Loss," but they're not actually for weight loss, right? We actually saw from a study that got released just yesterday at the European Congress on Obesity that people actually have the benefits of these, of treating their obesity, even if they don't lose weight when they're on these medicines, right, kind of thing. And so, if we had been able to convince one of the last 3 administrations during that time, if, these aren't agents for weight loss, and we had coverage for these at that time, we would not be in the situation. The company wouldn't have released these drugs at, $1,000 or $1,200 or $1,400 a month, because that's the only way they can survive, because there's not widespread coverage. When there becomes widespread coverage, the prices can come down. And so for me, I think the lever that we need to pull now is honestly for government to step in and say we're going to require the coverage of these, and we're going to find a reasonable way to distribute them moving forward, and that probably will include some price negotiations. No offense to our friends in pharma, but the reality is that you can't have a drug that's life-saving and life-changing, and they be as expensive as they are right now. So.
I think that the trend towards looking at the specific differences that relate to diseases in different racial ethnic groups is something that could be a real aggressive initiative with both the academic sector and the industry and regulatory sector, because what I've seen is that when you get enough people questioning on the basis of science, you do start seeing the narrative change. But it's probably fair to say that most people had never thought to question these things. It was essentiality. There's something different about these people, and that's what's causing it. I think that there are now enough arguments. You mentioned the pulse oximeters and these other conditions where the specific factors would replace the global in or out type of thinking. I also think that we should consider how to leverage socioeconomic factors that affect all racial ethnic groups in getting policies to change, like child care. Everybody needs, who needs child care, but some people are in workplaces where they're less likely to have any benefits or latitude and so forth. Not to say that and to be careful not to say that the racial differences, for example, are socioeconomically based, because also educating academia that they shouldn't just control for it and look at the data on what's called the diminishing returns hypothesis, where you see some of the largest gaps in things like obesity in the higher income groups. And in black women, for example, the national survey data, there's no gradient with income to speak of, and there's a small gradient towards college education, college-educated black women being lower, but you might see fewer disparities if you go to the very low part of the income spectrum. The high income spectrum isn't the same for blacks and whites. wealth is not the same. Not too many. So I think that we should look at where the narrative is beginning to change, where there's good evidence, and train people to move forward. I also think that the community-based community engagement needs a lot of work. Perhaps educating citizen scientists from the affected communities would be useful, because the whole community has a socioeconomic gradient, a power gradient built into it that's very hard to erase. And I don't see the people. That's one reason, I'm aware of my own biases or perspectives, because when I look out in the waiting room, when I was at Penn Medical School, I saw my relatives. I saw people who were quite capable, survivors. But I could hear when the doctors looked out there, they saw a group of people without assets, going to be non-adherent, miss the appointment, and so forth and so on. So I think that we could really work on those issues, which are very concrete, and try to remove some of these strictly, racial or ethnic perceptions.
One of the things that stood out to me as I thought about this session is even from the clinical trial stage. When we're talking about treatments that have an opportunity or potential to be transformative in a disease process because there's a lack of similar treatments or a lack of similar treatments with the same level of efficacy, or it's treating a condition that has extreme prevalence, we do approach it in different ways at certain steps of the process. So for example, when it comes to FDA approval, they will fast track a medication that is extremely effective, no other options, there's a great need. But I think that at every layer of that process, there has to be another approach, or else you do run into some ethical considerations. So for example, at the clinical trial level, when we look at the trials, as Bill outlined in his slides, there's a lack of diversity many, many times. And even if you looked at some of the most recent trials that were looking at GLP-1s and the cardiovascular effect, the number of diverse populations that study was extremely low for a population that has the highest rates of obesity, as well as some of the highest rates of cardiovascular disease. So now you have a new indication for medication based on data that did not include a population that has the greatest need. So even at the clinical trial level, there needs to be expectations of involving, at the very least, the populations that have the largest prevalence of a condition that you're trying to treat. At the FDA level, when these things are reviewed, we really have to say, okay, if we're going to approve a medication that's going to be transformative but is extremely expensive and has limited access because of rules on the books, et cetera, how will introducing this medication to the market change the trajectory of people's life? And what are the ethical considerations? Because you could have guessed that approving a medication that was extremely effective but had a red line in Medicare, likely not going to be covered in Medicaid, where you have extreme prevalence of a condition, is going to lead to worsening health disparities, right? So how is that conversation being had at the approval level? When then a drug is approved, what are the expectations at the PBM or the insurance level? Again, when we look back to the Hep C medications that were extremely expensive, when they became available, again, this is a population where you have prevalence, there's no other treatment available, this is a transformative agent, there was an expectation that every payer was going to figure out how they're going to do it, right? Some of them were at the forefront, some of them took a little time, but by the time we got done, whether you had Medicaid, VA, Medicare, commercial, you had coverage. And that's how we saw a transformation in the treatment of Hep C in the United States and around the world. We are now at a space where, okay, this is great, it's effective, it's been approved, we know it's not available to the majority of the population, but we're okay with that at some level. And that is a huge challenge for a health system that is committing ourselves to ensuring that every individual has an opportunity to improve their health at some level. Okay, we're not a place where we have a national insurance program, but through Medicaid, through Medicare, we're saying we're going to offer some level of health care to every citizen in this country. And so now, are we really saying that when there are effective treatments for a very prevalent condition that are just not covered whatsoever? And so as a clinician, where someone comes to me And in 2 seconds, I can look in the EMR and see their insurance and know exactly whether or not I can help this person, and whether or not this person is going to live out their best life, and whether or not this person is going to see their grandchild graduate from college, just by looking at the insurance that is in the banner on the EMR. And I think putting clinicians in a position where you can see a better life for someone through that door, but the door is closed, and it doesn't seem that anyone is even concerned about finding a way around the door, through the door, or cutting a key, that's not where we want to be, and definitely not in 2024. And so I think at every level, the trial level, the approval level, the coverage level, and then the supply level, which we haven't even talked about, right? Because even if you have coverage, where you live and which pharmacy you go to and your relationship with the pharmacist is also going to dictate your access to a medication that is transformative.
I'm confident we're going to solve this in the next 9 minutes. So I will say we have successfully, just through your responses to these questions, touched on pretty much all of the sectors, right? And identified some levers across sectors that can help us shift the trajectory of this technology. We've clearly identified some of the issues, although not all of the issues. But since we do only have about 10 minutes left, I want to turn to the audience, both here in person and online, for any questions that you have about the case. There and then there.
Hi, I'm Rick LeGros. I'm an OB/GYN reproductive endocrinologist, clinical researcher at Penn State College of Medicine. And I think one structuralism that isn't addressed is that we still need to solve is structural sexism. And women who are pregnant, women of reproductive age, are routinely excluded from these trials. I can tell you, like Dr. Knight, that we're using these drugs in the clinic to help women have improved fertility outcomes for women who've had bad pregnancy outcomes due to obesity to treat it, and yet we have no idea what the results are on pregnancy and the infant because of this. I've consulted for Novo Nordisk, no way. Picori got rejected, NIH got rejected. How do we find out in this population, I hate using the word vulnerable, but that's the FDA word, how do we find out what the effect is during pregnancy on the infant afterwards?
Yeah, it's a whole other access question that we didn't really engage with as yet.
Yeah, I think one of that goes to the clinical trial stage. So in most of the AOM trials, you're required to have any women of childbearing age on birth control, and you have to have that as an eligibility criteria. Two forms, of course. So there's not even a possibility in the trial to see that, and then you can't design a trial that you're going to encourage individuals. So you're basically waiting on observational real life data because you know that in real life, people, their fertility is improving, people are getting pregnant. So now we're on a trajectory to wait 10, 15 years to get that data. And so that goes back to, again, you have an agent, it can be transformative, there are trials that are going to be designed. What opportunities do you have to look at those criteria and say, I know that we usually do it this way, but we have an opportunity to change the trajectory for a whole population of individuals that are going to have health benefits. So what can we do at the trial stage and what's going to be allowable? And sometimes we have to think outside the box and not have to wait when there's an opportunity at the door for a population that's in need.
And worth acknowledging there that some of the denial of trials as of late by the companies are simply there is no drug, right? And Dr. Knight mentioned at the end, but there isn't a supply, right? We're only starting 25,000 people per week on these medicines. And when you read the media headlines, many of you probably thinking here there are 20, 30, 40 million people on these drugs. Well, there's 1 million doses of these drugs available per month, right? So it's not this huge scale, and there's so much demand. It's hard to then say, hey, we're gonna reserve some of this medicine for the next trial. But to your point, we need this data because, frankly, and we knew this from bariatric surgery data as well, you address your obesity, even very quickly addressing your obesity, your fertility increases, and there are children born, right? And we need to know what the results of that will be in the long term. So.
Well, I think that really highlights the point that SESTI and SESTI, one of the points SESTI and SESTI was trying to bring home, which is that we need to move consideration of these issues way up in the pipeline to prevent the downstream issues. Online question, I believe?
Yes, we have an online question from Dr. Anna Kirkland, who says, it looks like being on these medications can be unpleasant for patients. What if people don't want to take them or stay on them this can lead to them becoming even more non-compliant, seen as unruly, et cetera, which could then lead to an increase in stigma. So just curious for thoughts on that.
Yeah, I think this is a great question. I think whether it's personal choice, because we respect everyone's medical autonomy, right? There are plenty of people who live in larger bodies. I'm going to be controversial here. Plenty of people who live in larger bodies who do not have obesity. Okay, obesity is having too much body fat that harms your health. And so you can't look at someone and say, hey, they need to be on one of these medicines, just to be clear there. But there is that worry, right? Are we going to create more stigma if, for example, these do become widely available and people with larger bodies become less and less because of them? And we need to understand the consequences of that. So I think it is worth acknowledging that. And I think it is also worth acknowledging that not everyone can utilize these medicines, right? Some people cannot tolerate the side effects. And we've always had this in obesity care, right? We have plenty of obesity treatments. And unfortunately, the patient community, people like myself say, well, I failed this or I failed that. And actually the opposite is true, right? Those treatments failed you, right? We need to, you don't say I failed chemotherapy. No, chemotherapy failed me. We need to change that. And so we need to recognize that. Now, the good news is there's plenty of further development, and that's actually going to move away from some of these GLP-1s over time or move into some combination therapies. And hopefully we'll find new interventions for people who really need it. But it is worth it. The other thing I will say, because we talked about it, I know Bill talked about the mechanism of action of these, but if you talk to the patient community about this, how these medicines work, and this is maybe to a comment that Shariki made earlier, is, and I'll share my personal experience here, is that I don't think about food as much as I used to before. So I was in New York the other day. I walked 14 blocks to my meeting. First of all, my knees didn't hurt because that's the main reason I went on these medicines, because I was suffering from osteoarthritis, and it's relieved now because I've experienced some weight loss. But it doesn't matter how much weight loss it is. I don't have pain anymore. But I also wasn't thinking about every restaurant that I walked by down the street. And so that's a good thing, right, in some way, shape, or form. It also is something that may drive prevention efforts, like, because we have not been able to convince food companies for the last 20 or 30 years to make the substantial changes we think we need to make in the environment. And is it going to take something like this, which is maybe perceived, whether it's real or perceived threat to their business, to actually drive some of that change? Just something I've been thinking about.
But again, fixing the body is not the environment.
Well, the question becomes, though, what we don't have, and I want to be clear here, that we could, if I lived in a perfect environment, would I still have obesity? And the answer is likely yes, right? When we look at that, so perfect prevention is not treatment, right? So it's like, if I have skin cancer, I wear sunscreen every day. I'm from Florida, right? I wear sunscreen every day. But if I develop skin cancer, the doctor just doesn't tell me to put on more sunscreen. We do something else, right? And we acknowledge that. And so I think that becomes the balance here. We need both. We need prevention and treatment. And actually, I think the group that Bill and I and Shariki are part of, the Roundtable on Obesity Solutions, has done a really good job of that, bringing people together to talk about both sides of that formula and to say we can't, one without the other is not going to work.
Yeah, no, totally agree. And I wonder how that fits into the framework that Esty has developed, because we didn't engage as much because we were focused on emerging technology, right? So we didn't focus as much on the broader issues, and I think that that's worth bringing into the conversation. Other questions? Yeah.
Yeah, I think from the perspective of the heat map, I'm sort of pessimistic, right? I mean, I think that all the factors are there to create more stigma and greater disparity, right? First, in the clinical trials, the populations were not diverse enough, so we don't know whether these drugs are going to work as well with certain groups. Then it's expensive, so obesity may go down significantly in the populations that can afford it and that can get it. So for a condition that usually in society we blame the individual, as you sort of increase the disparities, it'll be easier to say, it's them, it's their behavior, it's their environment, right? So the solution would not be to get rid of these drugs, right? So there has to be a greater focus on trying to equalize the opportunities for treatment. But right now, everything that has been described here goes in the direction of being even a smaller group with a problem of obesity. And generally speaking, the smaller the group is, the more likely that people will blame the individual. So from the heat map perspective, risk is very high at a societal level, I think.
Thank you. So there are a couple of things I was thinking about, one of which was something you just said, is that we're thinking about a single technology, and we really need to think about the full breadth of technologies that are in the environment. And I think not only sort of what are all the, what are the prevention, what are all the treatment options, but then I think if you think about some of the policy things that have been around for, centuries, essentially, that have sort of facilitated and structured that are also part of this risk assessment. And we're, I'm watching the heat map and I'm thinking about this, and it's this very small box in a way, or at least the way I understand it, and that we're not thinking about this technology in the context, what other technologies can we bring to bear on this? And some of those technologies might be better for different populations than others. But then there's also this historical set of policies that have really set us up for this that I don't think a single technology is going to change.
I think it's really important that Bill shared it. That systems map that the Roundtable on Obesity Solutions does addresses all those other areas, right? And it'll be interesting to see, okay, I don't think we've thought about it, and Bill, you mentioned this, we haven't thought about, well, how will this kind of innovation in the GLP-1 space affect some of those areas? It may affect some, but it's for sure not going to affect all of them, right? And obviously we need to address all of them if we want to have real solutions.
Yeah, I was madly reading all of the little items in that map, and I didn't get to one that was about the person, about the physical state of the person. It was everything I saw was about the environment or the regulatory structures.
No, there were people up there.
There were, I believe you. I just wasn't fast enough to get to them.
Well, we published that, or the Roundtable published that, and I think it was in it. Was it a supplement? How did we do? I can't remember. The what?
It's in the Journal of Current Problems.
Current Problems.
So I stopped subscribing to Groupons because every other offering in Groupon is a commercial option for prescription of semaglutide or tirzepatide. Sorry, I was having a TIA there. So it's interesting in that the private sector has stepped in quite substantively to the weight loss business, and we obviously see a lot of this. And so as we think about an equity angle, should we also be giving more thought to the social and business constructs surrounding weight loss that the health teams, healthcare teams are not always used to interacting with?
I think it's really important. I will say that in absence of insurance coverage for these things, and entrepreneurial people have done that, I will tell you that most of those products you see advertised are not the brand name medicines that Bill mentioned earlier. They're likely these compounded products that are probably only allowed currently legitimately because of the supply shortages, right? And so maybe when we solve the supply issue, some of that will go away. But honestly, we've always struggled with that in obesity because we don't have this system that provides care in the healthcare system. People turn to snake oil, malarkey, whatever it may be quite often.
It's a safety issue, though.
And it's a safety issue. And honestly, I told this story all the time, but I have a professor in college who, when we were doing marketing class long before I was in obesity, and said, we're going to market the perfect product, and it's going to be a weight loss supplement, and we're going to promise everybody that if it doesn't work, we're going to give them double their money back. And the professor said, and everyone in the class is like, well, we were naive, we didn't know this. You're going to lose all your money. Everyone's going to ask for their money back when it doesn't work. And actually, he responded, no, they won't, because he understood the internalized bias that people with obesity have is that they think they failed it, so they're not going to ask for their money back. And we've got to change that in our culture, right? We have to say, it's not okay for someone to market this to you. And my advice would be not to use those things, to go see someone like Dr. Knight. But if you do use them, then you need to report that these things aren't working and they aren't legitimate, right, kind of thing, and that they may be harming you from a safety standpoint. For sure, you should not be getting your GLP-1s from anyone other than a qualified medical provider.
And just very quickly, I think we also have to avoid blaming the patients that go and use those Groupons or do go to the places. For me as a clinician, my head is exploding because I'm like, why would you go to the med spa to get this with no clinician in the house? But understanding that that weight loss has been a multi-billion-dollar industry for decades because people who are living with obesity have been trying to lose weight. And so even the stigma that people are looking for an easy way out after they spent thousands of dollars a month on the gym memberships, which are not free. I mean, just think about it. All of the things that we encourage patients to do have a cost associated with it. Eating healthy, getting active, going to the gym, finding time to do that, and to keep your household together. All of that is resource need. There's a resource need to all of that. So we just, again, want to think about why are we continuing to be in a system where something that has no evidence behind it, huge safety issues coming through an email from a sender we don't know, being picked up so quickly. And how did we fail as a system, and how can we correct that?
Yeah, I wanted to pick up on the point about the marketing in a slightly different way. Target marketing or racialized marketing has been extremely effective with communities of color, not in the right direction. The statistics are so bad that you would wonder why they're not hiding this, but it is actually considered good business. And some of the donations and charitable things and relationship building with like Black organizations and communities makes it even worse because their relationships with the community may be better than the relationship with the health system. I worry that this direct-to-consumer marketing by the pharmaceuticals could somehow cause harm on an individual or collective level. And I'm not sure where that fits in the heat map. I kind of looked for it, but that might be a regulatory target because of the nature of these medications that you can't apply to food, which is, safe by definition, FDA definitions. So just keep, we haven't talked about the marketing, but I had more calls. I don't do any work with pharmaceutical companies. I had several calls trying to get me to talk to the pharmaceutical companies to help them market to my folks,
So do we have people trickling back in from the other?
So they just wrapped upstairs, so they should be downstairs in about 5 minutes. So if we have one more quick question, we can maybe take that. Or we could also just give folks a little bit of a bathroom break. That is fine as well.
Well, I would like to ask one more question of the whole panel and just go down the line from Bill on down, which is, if we were to take this conversation forward and really wanted to make progress, not on the whole ecosystem, because that's impossible, but on one targeted sector of deployment, what would that be? Like, who would equity playbooks were mentioned this morning. Who would we work with? What community or sector would we work with to develop the first equity playbook in this space? Bill.
I was hoping you'd call me later. I think that there's a lot of room for provider education. How to talk about this problem, how to use shared decision-making, an awareness of how to use these drugs. What scares me the most about these drugs is that we know that primary care docs don't do a good job of treating obesity. That historically what they say is, you're fat, you need to lose weight, you need to eat better, you need to move more. People with obesity have already done all that multiple times, lost weight and relapsed. But that conversation about what to do about obesity and to understand, I'm coming back. So what scares me the most about those providers is that they're now going to say, take these medications and call me in 6 months without the kind of rigorous follow-up that these patients will need.
So many options here. I will zoom in on at the payer level. I think that, again, we're in a free market system, but there has to be some expectations, as we've done for preventive services, when there are effective treatments that are available, that are evidence-based, and there's a huge population that you are covering that is paying premiums to you, what is your responsibility for access? And how are you going to solve for the disparity within your own patient population as a result of a lack of access?
I'm going to throw out a very specific item. I've talked about a lot of them already that I've thought about, but one of the things that is something that could immediately improve access to care would be for our friends in the pharmaceutical industry to actually develop true patient assistance programs for people with obesity. So unlike other diseases, right, where you can get your medicine for free or for $25 if you have low socioeconomic status, they don't do that for obesity. Now, part of that's because of supply shortages and things along that, but it's time for us to move past that, actually create that, and that would at least let some people of lower socioeconomic means access these medicines.
Yeah, my answer is 2 words: food sector. I think the food sector has enabled the problem, and whatever power and influence that can be leveraged to get them to begin to recognize what needs to be something needs to be done, and what that is would be really good use of effort.
Thank you all. Please join me in thanking our panelists.